Thanks, Larry. It is good to be back. I think maybe it was 3 or 4 years ago, and I believe I had the same topic. But I'm luckily with computers, you can go back and look at your talks 4 or 5 years ago and make sure that none of the slides are the same or the concepts are the same. And if you know me over the years, you'll notice that I am got a lot of plasticity in the way I approach problems. So the way I approached chronic prostatitis 5 years ago is entirely different than the way that we do now. Now, I like to think that it's completely evidence-based, but as you know, evidence-based medicine starts on a foundation of experience and expertise in the problem. So actually, I've learned to start at the bottom and work up. As Andrew McNeely used to tell me, I used to do the studies to prove what I already thought I knew. I don't know if that's true, but in some respects, it might be. But what I want to do is talk about a little bit of the clinical science that we've been doing, but basically make this practical. In other words, when I'm done, what I have to say today will make a difference when you go to clinic and actually see your next patient who's a male with a chronic pelvic pain syndrome. So I've got to figure out, oh, there we go. So what we're looking for is, when we put this together, is diagnosis, classification, and treatment. Well, that's pretty well what we do with every disease. But what we're looking for is, how do we go forward with the evidence that we have today? How are we going to look at March 2012, how to manage the next patient we have based on all the work that we've done in the past little while? Now, what I want to do is just look at Category 3, chronic prostatitis, chronic pelvic pain syndrome. These are the patients that don't have recurrent urinary tract infections, but these are patients, when you do the proper evaluation, sometimes you find bacteria, which may or may not be related. We classify it as inflammatory or non-inflammatory, something which I don't expect, wouldn't want, and I don't think you need to do outside of a research setting, because we've never found in any clinical studies a differential treatment effect, whether or not we see white blood cells under the microscope in the express prostatic secretion or not. So how prevalent is it? Well, you know, some of the cancer guys will say it's not very prevalent at all, and the reason is, of course, is that when they see a chronic prostatitis diagnosis, that quickly gets shunted to one of the junior colleagues, and I've seen that in many academic centers. But once you're out in clinical practice, you can't do that. Shun it back and forth. I see that. It goes upstream. It goes upstream here. Okay, well, the plumbing runs differently in Vancouver than it does in other parts of the world, in the academic world. But, you know, how prevalent is it really? Well, we did a survey across Canada, pretty good prevalence study. It was a 2-week audit in over 100 urologists' office, looking at, you know, how many IC patients they saw, how many prostatitis patients they saw, new and old, and how they managed it. Well, it turned out that 3% of the males that walk out of the average urologist office week leave with a diagnosis of chronic prostatitis. So that's reasonably prevalent. In the United States, that's 8%. In Italy, it's 12%. In Mexico, it's 23%. So there is a bit of a cultural difference, and probably the reason is that Canadian urologists are too busy, really, to see the bulk of them out there. Because in the community, 6% of men have chronic prostatitis-like symptoms, and 1/3 of them within the last year have complained to their family physician about those symptoms, and less than 1/3 of those get referred along to a urologist. So it's quite prevalent. If you look at the physician study in the United States, where they looked at physicians, veterinarians, male nurses, dentists, people that should know, 16% of these medical professionals in this survey, 16% said that they had or had a diagnosis at some time of chronic prostatitis. So again, it's quite prevalent. Now, when you've had this condition for at least 1 year, what's the impact? Well, the impact is quite significant. The impact is definitely more than some of the other prostate diseases. When you look at actual impact, the impact on a patient with chronic prostatitis in 2010 was much higher than a patient with prostate cancer in terms of disability, primarily because they're younger. In terms of quality of life, the quality of life of a patient with chronic prostatitis for 1 year is equivalent to somebody who has a bad congestive heart failure that's difficult to treat, somebody within 3 weeks of acute myocardial infarction, somebody with unstable diabetes or active Crohn's disease. These patients have an extremely poor quality of life that not necessarily gets better, unless, of course, they come to my clinic. No. So last night we talked about something that I like to call the clinical picture. It's something that, as urologists, probably because many of us have our faces up Da Vinci's butt and really don't have an idea what's going on in the real world, is we kind of forget the whole clinical picture, that there's more to urology than PSA and Gleason 7. There's much more than that. We have to put it together, and we have to do that when we're actually looking at a real patient with something a lot harder to deal with than a urologic malignancy, which basically I think now I could take somebody out of high school and train how to deal with prostate cancer. Certainly there's no need to go to urology residency to learn how to use a robot, for Christ's sakes. Anyways, see, I got prostate cancer in. So the clinical picture, and I'm going to jump right into this because this is what I usually left for the end, but now I'm going to start with this because basically chronic prostatitis patients, like IC patients we talked about last night, with a lot more evidence, do have various clinical phenotypes. And we've published a number of times and actually got this into Campbell's finally, is the Snowflake Hypothesis. Snowflake Hypothesis being, as you can realize, that every patient looks alike, however, every patient is really different. And in fact, we just happen to have the 6 points of a snowflake, the 6 clinical phenotypes that predominate the prostatitis patient's life experience. Then basically we can take a prostatitis patient and look at them. Instead of Gleason grade and stage, we look at urinary symptoms, the psychosocial aspects, whether or not there's organ specificity, like it really is the bladder, or sorry, the prostate in this case actually involved, whether or not infection may or may not be involved, whether or not they have some systemic manifestations of this, and whether or not they have pelvic floor dysfunction. Now, I'm throwing this out here primarily because there's residents here. This is from the CUA guidelines published in 2011. I'm going to go over them very quickly because it's important, for exams and also for clinical aspects, what we think you really have to do. And it's quite easy. You have to do a history to try and figure out where they're in these phenotypes. We certainly recommend that you use some sort of instrument to be able to explore the patient's pain and voiding experience. CPSI is good because can be filled out in 5 minutes. It looks at the locations, the frequency, the severity of pain. It looks at the obstructive and irritative voiding symptoms, or the storage and voiding symptoms. It looks at impact and quality of life. And within about 10 seconds, I can look at that and understand where this patient is coming from, but it also allows me to monitor the patient through a treatment process. We like to, you must, if you're going to assess a patient for prostatitis, you must check the prostate. If you're going to check the prostate gland, you've got to do a prostate massage and then collect the urine afterwards and send that away for culture. And you'll find in at least 16% or higher that you'll actually find a uropathogenic bacteria. Gives you at least a license to write a prescription for a fluoroquinolone antibiotic. We don't recommend semen analysis and culture except if the patient complains of foul-smelling semen. The urodynamics are optional. Serum PSA is definitely not recommended for routine evaluation of a prostatitis patient unless you're doing the PSA for another reason. What's the other reason? Of course, it's screening for prostate cancer. And if that's the reason you're doing PSA, that's the reason you're doing it, not because the patient has prostatitis. Routine imaging and cystoscopy are only indicated if you actually have indications for this. And we look at psychological evaluation in selected patients, primarily those with profound depression. Now, this is the traditional approach to the evaluation of a man. It's in the guidelines. It's the way that we've traditionally done it. So forget the one on the left. These are the CPPS. So you do your history, physical examination, urinalysis midstream. If they have recurrent urinary tract infections, in our clinic, that's when we do a 4-glass test I would never do that in clinical practice, but I would at least culture the urine after prostate massage. If the infection is localized, treatment for category 2. If the patient doesn't complain of infection or bacteria, but the 2-glass test, you grow an E. coli, Pseudomonas, or Klebsiella, that's still category 3 because they don't have recurrent urinary tract infections. You treat with antibiotics, then reassess. We do the other investigations. Then traditionally, if I'm not going to go through these, but if they have certain symptoms like hematuria, obstruction, urethral symptoms or discharge, other abnormalities, semen abnormalities, abnormal DRE over 45 years old, major psychopathology or extraprostatic pain, you do these other evaluations. That's the traditional approach, and there's nothing wrong with it. We do it in our clinic, but we evaluate it differently. And the way we evaluate it is we try and use what we find with this approach to differentiate the various phenotypes. Patients can have 1, 2, 3, or up to 6 of these basic phenotypes. And you can see, it's easy. If they're voiding symptoms and these others, we put them as a urinary category. If they have depression, maladaptive coping, social dysfunction, stress, or anxiety, we put them in the psychosocial category. If the patient has discomfort or pain on the same DRE pressure that you use to examine BPH or look for nodules in the prostate cancer, and that's the pain, they're organ specific. Now we are working on the Mips Program, which is millions of dollars, looking for better biomarkers, and we may get them. For right now, this is what we can find clinically. If you find uropathogens, despite the fact that they've never had a urinary tract infection, we put them under the infection category. If they have, as many do, pain beyond the prostate gland and have IBS or fibromyalgia or neurologic or systemic, and if we find, as about 30% of patients have pelvic floor dysfunction, spasm, or pain on examination, it's the tenderness. Now, what realistically are you going to do? Well, realistically, you only got a couple minutes. So what you do when you find out a patient has prostatitis is you back out of that room as quick as you can, because you got other important things to do, patients down the hall, and you give the patient the CPSI, because then you don't have to go. The patient wants to tell you where his pain is, how often it occurs, how severe it is, what voiding symptoms he has, how it's impacting on his quality of life. Let him do the check boxes where you see another patient. Patient appreciates it because you've actually explored what he wants to do. That's the important part of the history. But then you also have to see, particularly my history, is how many other urologists you've seen, how many cystoscopies and MRIs you've had ordered over time, how many other urologists have been poking in and around and doing various things, how many antibiotics you've been prescribed over the last several years. I have to do that because I'm in tertiary practice. Then you do the focused physical examination. The focused physical examination, of course, is suprapubic, external genitalia, and then we come to the all-important digital rectal examination. Before you do the digital rectal examination, you have to assess the perineum and pelvic floor, and you do that with just finger pressure on the perineum, and you can assess whether or not, yes, doctor, that's the pain I'm having. It's in the perineum. That's probably a pelvic floor pain rather than a prostate pain syndrome. Now, the DRE is important. Now, I should go through this, but I don't have to because I know you guys have prostate cancer experts here. So you're probably taught how to do a proper DRE. But just in case you're not, I think I better teach you, because I did the residence yesterday. And you guys missed out.
You need a volunteer?
Larry, if you're willing, I'll show you exactly how it's done. But we'll talk about that later, offline. Yeah.
The word catastrophizing.
We're going to get to that.
Did you make that up, or did Martin give you that?
He learned it from me.
It's actually the residence after an Andrew Friday afternoon.
Yeah, well, we'll go through catastrophizing because that's kind of interesting. But let's look at the DRE, because I look at the residents there. So at the turn of the century, if you guys were residents and you had a real rich grandfather or father, you did not go down to Cleveland Clinic or across to Seattle and do a robotic fellowship. What you did was called the European tour. This is pre-First World War. And what you did for 1 or 2 years, as long as, depending on how long your dad or uncle's money ran, is you went around Europe and you met European girls and drank. But what you're really supposed to do is you're supposed to go to one institution, one in Vienna, one in Berlin, one in Paris, one in Stockholm. And one that you always went to was the one in Stockholm. And it was the Royal Stockholm Institute of Prostate Massage. And there you would spend about 2 weeks of your time, on the in Sweden, in Stockholm, learning about tall, blonde Swedish girls. But really what you would be learning is how to do a proper DRE. But even more important, how to do the prostate massage. And we actually have descriptions in the literature, guys coming back and then describing it to their American colleagues who really didn't have a chance to go over to Stockholm and learn how to do a proper DRE. So after 2 weeks, you'd be an expert. But what you'd learn, as we explained to the residents yesterday, is when you do a DRE, you stay away from the prostate gland. What you do is you check the pelvic floor. First, you check the rectum, make sure they don't have cancer. And, occasionally, maybe once in our career, we're going to poke our finger in and find something in there that's not going to be there. Every urologist usually finds 1 or 2 of those in their career. And it's kind of a coup. So you do that first. Most of the time it's just hard stool, but that's beside the point. Then you go posteriorly and laterally, and what you want to do, you're looking for painful pelvic floor, and you're looking for myofascial tender points. Then and only then do you check the prostate. And again, like I said, you palpate it very lightly, and you see whether or not that replicates the pain that the patient has. If it does, then they have prostate-related pain, prostate pain syndrome, or the organ-specific phenotype. And prostate-specific treatments might be of benefit. Then, of course, you bring the patient to his knees, tears to his eyes, and you really let him know that you care for him because you just do the prostate massage. Now, the problem is most urology residents are not taught how to do a prostate massage. I forgot to ask you yesterday in the residence, do you guys have a session on how to do prostate massage here? Yes? No? PCA 3, do they teach you? That's not the type of prostate massage you do because you want actually prostate fluid to get into the prostatic urethra. And there's 2 ways. There's the way that the urologist that doesn't know what he's doing does, and that's the sweeper. The sweeper, what he does is he puts his finger in and he sweeps it from lateral to midline base. And the sweeper causes a lot of pain. It causes pain in somebody without prostatitis because what you're doing is you're pulling the rectal mucosa across the prostate and causing pain. What you want to be is a roller because a roller is the way you were taught to do it in the Swedish Institute of Prostate Massage. You start laterally and you roll your finger into the midline. So if you learn nothing else this morning, next time you do a prostate massage, you're not going to sweep your finger, you're going to roll your finger. You probably already knew that. Condition-specific questionnaires, the CPSI we talked about. Focus questionnaire, we're developing a specific questionnaire, and it's going to be evidence-based, based on hundreds of patients who have filled out depression, catastrophizing, abuse, associated condition type questionnaires, which will be about 12 questions and allow you to phenotype. Depression is a problem, but mild depression is something we can actually identify, kind of approach. Severe, profound depression, the patient will never get better. They need a psychologist. Catastrophizing is something we talked about last night, but it's, again, the patients with prostatitis are particularly, it's particularly tough on them because they don't do well, particularly if they're in the later stages of catastrophizing. Catastrophizing, as you know, has 3 stages. The first being rumination, where they're thinking about the pain all the time. The second is magnification, where they go through a stage where they magnify the amount of pain they have. And finally, there's the catastrophizing syndrome of helplessness. If we identify them as helplessness, we now know that that patient will never, ever respond in a clinical trial. So all the clinical trials we do now, we've advised industry that if they have a helplessness catastrophizing score of over 31, they will never get better. So if I see that in my clinic, and unfortunately most of those patients have already gone to narcotics or other illicit drugs as a way to help their pain, those patients don't do well. But we do pretty well in patients with magnification and rumination as long as the patient's willing to accept the fact that they're thinking too much about this, their magnifying is not that bad, and we actually put them to a cognitive behavioral program. We look for IBS, fibromyalgia, but it's much less predominant than in the female patients. The urinalysis is out of the midstream urine. The culture, that's the post-prostatic massage urine sediment or specimen, easy. Midstream urine, and after prostate massage, once they can stand up and don't fall over, they go and they produce the first initial urine, and you send it for CNS. The cystoscopy, urodynamics, and others.
Just to be clear, are you doing a gram stain?
No.
So you're not looking.
Oh, I do. But you guys aren't.
But you said that the whites, it's irrelevant.
Right. I do because we have to identify, because someday we may find a treatment effect or some differentiation in the patients with that we actually identify inflammation. Right now, we've never been able, when we stratify the patients, and we've even a priori stratified them to inflammatory and non-inflammatory in clinical trials, we've not been able to see a differential treatment effect, even with stuff like anti-inflammatories. So that's a good question. So if I was in private practice, I wouldn't really wheel in the microscope for these particular patients. Now, there's been 4 studies, and there's actually 5 because the Taiwanese and the Koreans, Koreans just published theirs, and the Taiwanese have got theirs in review, that they're looking at patient populations and being able to phenotype them. But let's look at study 1, the first one that Danny Shoskus and I put together. We noted that about half the patients have urinary symptoms. About 1/3 of them have some sort of psychosocial or psychosexual problem. Most of it can be dealt with by the uropsychologist. That's us, by the way, the uropsychologist. And why I say a uropsychologist is because we have to be psychologists in urology now. And why I think we're not as bad as we think we are is because some of us can actually diagnose prostate cancer in men and then turn around and convince that man that not only does he have prostate cancer, but he doesn't need to do anything about it. We're just going to keep an eye on it. If you can talk a man into active surveillance, you must have some sort of people skills. Otherwise, the guy's not going to believe you. Organ specificity, as you can see, it's different by the different definitions of different countries. But we found about 16%, and another study, 10%. About 1/3 of the patients have pain outside the prostate, and about 50% or so have pelvic floor dysfunction. Study number 2 was Scandinavia. Study number 3 was a European study, German, Italian cohort, and study number 4 was a Canadian American cohort again. We saw the same thing in IC, that the number of positive domains relates to the symptoms. So you see the total NIH CPSI. So if they have one phenotype, that's usually organ-specific, pain in the prostate, only 1 in 5 patients have that. So it helps 2 things. Number 1, his symptoms are going to be less than the ones with higher domains, and we can aim his treatment at his prostate, and we don't have to worry about all the other things. But as you can see, if they have 2 domains, 3 domains, 4, or unfortunately 5 or 6, their symptoms become much more severe. Now, what's also important is it doesn't matter how old or young they are, they have about the same number of domains. But as in women, we see the same thing, is that the longer they had the duration of symptoms, the greater the chance is that they have more of these domains. Now, in females, I presented last night that we've actually been able to look at this phenotypic progression from local organ-specific pain to regional pain syndromes to systemic pain syndromes. We've not been able to do that in men quite the same, is because men, for some reason, and it's probably a gender difference, do not tend to go into the systemic pain syndromes like fibromyalgia, chronic fatigue syndrome, migraines, and the like, as women do with chronic pelvic pain. Here is the most important message of this phenotypes. What drives the patients into our office? What impacts on their quality of life? What changes what they do day to day? What keeps them disabled? Is it the urologic problems of the urinary voiding symptoms? Is it the prostate pain? Is it the infection domain? No. It's the 3 things that we ignore in our prostatitis patients. The psychological or psychosocial problems. We forget about the neurologic and systemic ramifications, and we ignore the pelvic floor. Yet these are the most important domains. So no matter how good a urologist you are, no matter how you take care of that prostate-related pain or improve their voiding, if they still have these other domains, the patient's going to remain an unhappy camper. So let's look at treatment. So we just published that in JAMA last year, and what's interesting is this is the very first network meta-analysis ever accepted in a reputable journal. When I say that, like New England Journal, Lancet, or JAMA. And in fact, the JAMA statisticians had many problems, and it actually took us months and months. And luckily, that the statisticians that I had, particularly the last author, the second to the last author, and John Attia, he actually sort of invented network meta-analyses. And this is one of the first approaches that we've had. Now, network meta-analyses are kind of interesting. What they are is we have these multiple clinical trials, and we have over 300 in prostatitis. About 23 of them are reasonable. And what you do with a network meta-analysis, instead of looking at an alpha blocker versus a placebo in a single trial and another one, like we do for level 1 evidence and grade A recommendation, is you pretend and you make up a clinical trial and amalgamate all 23 clinical trials, and all the patients in the clinical trials that were on placebo are in one group, all the patients on alpha blockers are another, all the patients on anti-inflammatories are the other, and then you can compare alpha blockers to anti-inflammatories where there's no clinical trial that we could ever do that. And when we do that, we come up with something different. I'm going to show you that first, but the first one is the systemic review. We all know what that is. And when we come with a systemic review, it lets us look at the individual clinical trials. And this is the traditional therapies based and their recommended evidence based on systemic meta-analyses. Now, I'm going to go through this because I think it's important, particularly for the residents, to know what's recommended and what's not. Antibiotic therapy for newly diagnosed antimicrobial naive patients are recommended. In other words, if you get a patient, which we very rarely get, who has prostatitis, organ-specific, and they've never been on an antibiotic, it's worth them to try a 4-week of fluoroquinolones, and they have a 40% chance of responding. However, look at the recommendation, 4D. That's pretty low recommendation. Now, antibiotic therapy for patients who have failed previous antibiotic therapy, so let's say they've been on a Cipro. So what are you going to do, put them on doxycycline or Levaquin or something else? Well, that's not recommended, and now we've got high-grade evidence, 1A. Alpha blockers, first-line monotherapy. Do you put a patient on an alpha blocker even if they're avoiding symptoms? It's not recommended because it does not work as a monotherapy. However, it does work for newly diagnosed alpha blocker naive patients with voiding symptoms as part of a multimodal treatment strategy. We do have evidence for that. Anti-inflammatory monotherapy, not recommended. But as part of a multimodal therapy, yes. The phytotherapies can be recommended, but they're most effective when we use them along with other therapies. 5-alpha reductase inhibitor therapy is not recommended unless you use it in a man with prostatitis and large prostate and obstructive LUTS. That's a BPH patient with prostatitis. Yes, it does work, and there's reasonable evidence. Individualized multimodal therapy directed towards a defined clinical phenotype, we're now gathering the evidence, and now it's 3C as a recommendation. I'll show you what. The surgeries are not recommended. Even minimally invasive surgeries are not recommended unless you actually have an indication. These are the potential therapies that we're using in our clinic or working on right now. Everything from heat therapy, biofeedback, physical therapy. We use psychotherapy. Acupuncture we're working on. We have an acupuncturist for some patients. Electromagnetic stimulation. There's no real good evidence the use of muscle relaxants, yet we use a lot of them for patients with pelvic floor, particularly the old cyclobenzaprine or Flexeril. It's effective when you use it with other therapies. The neuromodulating agents, we're starting to collect evidence on the gabapentinoids. We just finished published in JAMA in the fall of last year, our Lyrica or pregabalin trial, tricyclic antidepressants. We just published that in the Journal of Urology. Pudendal nerve modulation of some sort, and surgery when indicated. So here's a traditional therapeutic approach, the stepwise approach that comes out of Campbell's and our traditional approach. This is the approach that is in the guidelines because this is the evidence that we base on the systemic review. When you use this approach, it's doomed to failure in most patients because it's step-like. So what you do is you put them on an antibiotic trial. If that doesn't work, if they have obstruction, you put them on alpha blockers. If they have pain, you put them on anti-inflammatories. And then if that doesn't work, you put them on phytotherapy, or if they have bladder symptoms, you put them on Elmeron, you put them on finasteride, and then you work down step by step, finally, neuromodulation, maybe using heat therapy or microwave thermal therapy or surgery if there's an indication. This stepwise approach is what we used to use in our clinic, and it didn't work. 30% of patients is their expected response. In other words, 30% of patients are happy. That is not a happy clinic to be if that's the sort of success you're getting. So what we did is we looked at this network meta-analysis. Now, the network meta-analysis is the stuff that nightmares are made out of, because we first put this into a 3D type of model, and you couldn't make head nor tail. So this is a 2D, and when you'll see it, you'll see exactly what I mean. So this is the network meta-analysis that we published in JAMA. And basically, it's comparing everything to everything in a clinical trial. Now, I'm not going to go through this because we simplified it for urologists, and it's coming out in several months in British Journal of Urology, because I show this to urologists, and even guys that are really smart, like those guys in the second row there, they're not even sure how to interpret this, and I had nightmares. So we simplified this, and instead of, this is the symptom score difference between placebo and alpha blockers, or comparing everything else. So we can compare everything to everything in the overall grab bag of patients. But what's important to patients is what's the chance, that we call it the relative risk, of them being a, not a survivor, but a responder. What's the chances that we put them on there, they're going to be happy with their clinical response? And we get something a little bit easier to interpret, and we look at the relative risk of response of one medication to another. For instance, let's look at alpha blockers in this particular one. You can see that alpha blockers if you look at that from placebo up to alpha blockers, 326 patients, alpha blockers, 609 placebo, the relative risk of being a responder in the 5 studies that have responder analyses is 0.26, so almost a 30% chance of being a responder if they're on alpha blockers compared to placebo. But that's kind of difficult to interpret. So we decided for urologists in the Urology Journal to simplify it. So we updated it. Instead of looking at multiple therapies, we looked at the 3 A's: alpha blockers, antibiotics, and anti-inflammatories, which is really the foundation of our traditional approach. And even though there were 264 studies evaluating this, only 19 studies used a randomized, placebo-controlled approach where we had exactly the same type of evaluation, which is the CPSI, or Chronic Prostatitis Symptom Index. So this was a clinical trial made up, never happened, of 1,689 patients who, if we had done this clinical trial, 395 were randomized to alpha blockers, 132 to antibiotics, 166 to anti-inflammatories, 661 to placebo. This trial never existed except in the statistician's mind. But now we have something simpler. And if you take alpha blockers, placebo to alpha blockers, if you were on placebo or alpha blocker compared to placebo, you would have a difference in CPSI score expected in a population of 10 points. Well, 3 points is appreciable, 6 points is a very significant response. So all of a sudden you say, hey, alpha blockers work. But when you look at responsiveness rate, look at placebo and alpha blockers. The relative risk of being a responder with alpha blockers is only 40% compared to placebo. That's not all that good, because in some of the placebo-controlled trials, we've had as high as a 30% response compared to baseline. So our interpretation of this is, yes, these traditional monotherapies work. We get statistically significant, but modestly or barely clinically significant treatment effects. And there's a disconnect, and here's the thing, there's a disconnect between what we see in an overall population and what we see with our individual patients walking in the door. So what have we learned from this? We've learned that the medical therapies can remain as part of our treatment strategy. They do work even in a population-based study. However, monotherapy is not very effective. It's effective in an overall population, sort of like you have the same problem when you're looking at prostate cancer and you look at what's happening in the overall population. We're reducing the death rate, the mortality rate in overall population, but an individual patient wants to know what's actually going to happen to him. And when we actually look at that, the monotherapy is not very effective. So we believed, and this was about 3 or 4 years ago, the eureka moment, that phenotypically directed therapy would likely be the key to success. Why do we think that? Is because we were doing something terrible in these chronic pelvic pain syndrome. We were lumping them all together at the same. Why would we do that? Because the next patient I see is a patient with prostate cancer, and I'm not going to treat a patient with a Gleason 6, 2-core, PSA 5 the same way as I treat a patient with metastatic prostate cancer and Gleason 9 and a PSA of 100. Yet that's what we were doing with chronic prostatitis. We were not differentiating our patients like we do with bladder cancer, like we do with prostate cancer. How come? is because we had a different mindset. That's what we have to do. We have to do the same thing the way we treat our malignancies. We have to differentiate, categorize, classify, and then direct the appropriate therapy to the appropriate patient, the way we've learned to do otherwise. And we use the U-point. And basically, without going into a lot of things, you remember we found out how we put them in the U-point categorization, which is right there. Then what we do is for each one is we use specific therapies based on our systemic and network meta-analyses of what works for the overall population, but we point it to the mechanistic or location that we're actually treating, in other words, the phenotype. And you can see we use the same therapies so that a patient with only one, like organ-specific thing, we can treat them with something different than we treat organ-specific plus urinary plus some psychosocial or pelvic floor problems. But multimodal therapy is the way to go. So does it work? So we just published, Danny Shoskis and I, 100 consecutive men with CP, CPPS. We clinically categorized them to U-point. We treated them according to that algorithm. We followed them for 6 months. And what we saw is 84% had a 6-point fall in CPSI. That's compared to our monotherapy trial done exactly the same way, where we had a 32% response. When we use indiscriminate multimodal therapy, like the 3As, alpha blockers, antibiotics, and anti-inflammatories, we get that up to just under 50%. When we actually direct our therapy to the individual phenotypes, we get an 84% response rate. We get a significant drop, you can see, of the CPSI, and 4 out of 5 patients reach their therapeutic goal. The same as I talked about last night with interstitial cystitis. You do not cure patients with chronic prostatitis. Patient has to realize that, and you as a physician has to realize that. This is not a disease that we cure in urology, but we can ameliorate the symptoms, improve their quality of life, and reduce the impact. And what we look for in a patient is a goal, and that goal could be reduction in pain. If it is, we're looking for a 30% reduction in pain. Maybe it's reduction in getting up at night, avoiding symptoms. We look for a goal that we can achieve. They want to go back to work and become less disabled. That's our goal. They want to be able to jog again. That's the goal we go for. And we go for goal-oriented, like we do with other chronic diseases, rather than cure. And when we do, we get a happy clinic. What's interesting, when we do the U-point directed therapies, and we divide the CPSI into pain, urinary symptoms, quality of life, or total, we affect all the domains. In the overall population, we improve the voiding, we improve the pain, we improve the impact, we improve the quality of life. This works. So what's the future? Well, the future right now, we're in year 3.5 of the Mips Program. That's the multidisciplinary approach to pelvic pain. We've got $42 million in 10 centers. And what we're doing is we're phenotyping patients. When we started, nobody believed in the U-point. But about 2 years later, we're now U-pointing every patient that's in this multi-million-dollar NIH trial. But what we're really trying to do is use biomarkers. We need the PSA of prostatitis and interstitial cystitis. We need biomarkers from the urine, the serum, to be able to better differentiate organ specificity, inflammation, pain parameters. Then we can use these biomarkers, we're hoping, to be able to better direct therapy, better than we're doing with U-point, which is nothing but a clinical assessment. Then what we hope to do, and MAP is going to be available in about 2 years. The NIH has already said they're going to fund at the same amount what's called the Mips Program. And it's going to be open to foreign centers as well. The Mips Program is the Multiple Intervention Pain Phenotype Study, which is basically going to explore what we did with those 100 patients. It's basically going to use a scientific approach in a large international clinical trial to do what we did with prostate cancer and bladder cancer, is differentiate patients and treat them differently. So the conclusion is that our classical traditional therapies do work in 2012. And although we don't have the evidence we would like, the high-grade evidence, we have enough evidence to say that we should change our treatment algorithm, and it's evidence-based, and rationally base our therapy by individually directing treatment towards identified patient phenotypes, so that each patient will have a different treatment plan. That treatment plan will be different goals and different therapies. So, but the follow-up will be still following up the same way. So that's where we are right now with chronic prostatitis. It's sort of exciting to be in because in the next couple of years, our MAP studies will have been completed, and we'll have hundreds. Like the bank of biomarkers that we're looking at is literally in the hundreds. We'll have that done in over 800 patients and 800 age-matched controls, followed for 2 years. So we'll have longitudinal data as well in that particular study. And then when we actually use that in the Mips study, you know, that's going to at least take me into retirement if I'm lucky enough to be one of the Mips investigator. So I'm going to stop there and take questions if I can there, Larry.